Hello everyone, welcome to the class and a little bit sorry for this little bit delay and because of the internet connection my Wi-Fi router was not working, so it was under repair. So if I am audible and visible to all of you, can you give me a quick nod? Right. Okay, hello Alicia. So I think Alicia is there. So let's start. This discussion is about breast cancer, and here all the topics are very important. And I will suggest you that you must read these discussion, especially this discussion, before going to exam because you are going to get one or two question from here, right? And I will suggest that this PDF of the lecture which I am going to take right now will be available at my Telegram group also. So if you want to scan, you can scan my Telegram group also, right? So in the end, I will be sharing you that link also. Yes, sir. So thank you so much to all of you for bearing this little bit of delay. So let's start with the cancer breast. So first, I will tell you, cancer breast is the most common cancer which is seen in females, right? It is more commoner than cervical cancer right now, right? So it can occur in both older individual as well as younger individual. But what is the difference? You have to remember, in younger individual it will be associated with hereditary breast cancer. So please remember, younger patient with cancer breast, they will be usually having association with hereditary breast cancer, right? So this is some simple no, there was no class at 6:30 because of my router was not working, Nairobi, so I have to conduct this class again. Right. Thank you, Himanshu. Thank you, Himanshu. So let's start. This is the question. I will be putting question in front of you. This is the first question. And then you have to give me your answer within half minutes or within less than that. And those who are giving me quicker answer, I will be naming them and then we'll be discussing about them. So this is the first question. Very good question it is. And this is from the update of the Robbins 10th edition. Which of the following is not associated with the breast cancer? Monoallelic loss of function mutation in the PAL-B2, biallelic loss of function mutation in PAL-B2, BRCA2, CHEK2. So what should be answer for this question? B. Okay, so I think Dr. Purva has given only one answer till now. Hodgkin's, A, D. Okay, so fine. So I think Dr. Purva has given me the first and correct answer also, right? Which is not associated with the breast cancer. So first of all, we should know that breast cancer is associated with BRCA2 also, right? So this is associated with the breast cancer. CHEK2 is also associated with breast cancer, and this is associated with radiation associated or radiation induced or radiation associated breast cancer, right? So that is associated with CHEK2. So CHEK2 and BRCA2 both are associated with breast cancer. Monoallelic loss and biallelic. See, there are one gene and there are two alleles, right? If only one allele will be getting lost, they will be giving rise to monoclonal things or monoclonal cells. And monoclonality is a sign of tumor. So right, you can remember like this. If there is a monoallelic loss, so this monoallelic will be giving rise to a monoclonal tumor cells. So this will be giving rise to monoclonal tumor cells, right? So that is what it will be associated with the breast cancer. Biallelic, there are two alleles, right? So if the two alleles are lost, it means it will not be monoclonal, it will become polyclonal. So that is why this is associated with Fanconi's anemia, right? So this is associated with Fanconi's anemia, right? So that is the point you have to keep in mind. So correct answer is B. Biallelic loss of function mutation in PAL-B2 is associated with anemia, whereas monoallelic loss is associated with the tumor, right? So now you got the answer. Answer is B. Now I will discuss about the genetics of the little bit glossary of the genetics of the breast cancer, which examiner asks very often in exam. So there are 4 genes: BRCA1, BRCA2, P53 and CHEK2 gene, right? So out of these, what we need to remember that BRCA1 is present on chromosome number 17 long arm. So please remember it is 17 long arm, which came in exam also, right? And they are most commonly associated with the breast cancer and ovarian cancer, right? And they are also associated with medullary carcinoma of the breast, and these are on molecular classification, these are usually triple negative basal type of breast cancer, right? So now you understand BRCA1 is chromosome 17 long arm, hereditary breast cancer, ovarian tumor. Most common association is with BRCA1, and they are also associated with which other variant of the tumor is medullary carcinoma of the breast, and on molecular classification they will be triple negative. Triple negative means ER negative, PR negative, and HER2 negative, right? And this will be the basal type of breast cancer. So this is the BRCA1. BRCA2 location is on chromosome 13 long arm. So remember, BRCA1 is 17 long arm, BRCA2 is on 13 long arm. They are also associated with breast cancer, and they are most commonly associated with male breast cancer, right? BRCA2, which is on chromosome 13q, they are also associated with luminal A and type B of breast cancer on molecular classification, right? So molecular classification, luminal A and B, most commonly associated with the male breast cancer, and their location will be on chromosome 13 long arm. So that is BRCA2 gene. P53 is the most common gene associated with breast cancer. So if you do not get hereditary history, so BRCA1, BRCA2 is ruled out, and most common will be P53. So that is why most common is sporadic, right? So this difference you have to remember. Most common sporadic is P53, whereas most common hereditary is BRCA1, right? So these are the two things we have to understand. And already I have told you CHEK2 mutation is radiation associated breast cancer. So that was again a very good question. This is this is given in the table of the Robbins, and examiner can ask this question in our future exam also, right? Now PAL B2 is the update from the Robbins. What is PAL B2? So PAL B2 stands for partner and localizer of BRCA2, right? So that is the full form of PAL B, partner and localizer of BRCA2 gene. And they have which kind of mutation? Loss of function mutation. So this mutation is called as loss of function mutation. So this loss of function mutation can be of two types, biallelic or monoallelic. As I said, when it will be biallelic, two alleles are lost, so they will form polyclonal. So this will be seen in Fanconi's anemia, right? But if there is a PAL B2 gene having monoallelic, so they will form monoclonal tumor cells, and monoclonality is a form of tumor. So which tumor? Breast and pancreas both. So this is another important point we have to remember. Breast cancer and pancreatic cancer both are associated with monoallelic. So remember, monoallelic will be forming monoclonal tumor cells, right? So now understand. So PAL B2 gene, if examiner says monoallelic, it will cause cancer. Biallelic will cause anemia. Is it clear to all of you? Right. Now moving on to the next question. This was the DNB question also. Male breast cancer is associated with mutation of BRCA1, BRCA2, c-KIT, or both A and B. Very good. So I think here why Mintu, you have given two answers, 4 or A. So correct answer, first correct answer I have got from Nitish. Dr. Nitish has given me the first correct answer. It is both A and B, right? So it is both A and B. So correct answer for this question is, see, I will just tell you one thing. Question is associated with. Examiner did not ask about the male breast cancer. See, question is about male breast cancer, right? Question is about male breast cancer, right? Male breast cancer is associated with. So this is again a very, very important thing. It is not asking about most commonly. So please remember, it is associated with both BRCA1 and BRCA2. So both BRCA1 and BRCA2 are associated with the male breast cancer, right? This is a very, very important thing we have to remember. BRCA1, BRCA2, both are associated. So when examiner is asking who is associated, both will be associated. So answer should be D. Now understand, answer should be D. So that is why you have to look at the language. If examiner would have asked which is most common, then your answer will be BRCA2 is most commonly associated with male breast cancer, right? So now you got this point. So please check this language. This was the DNB and NEET question. So this is how examiner will be asking, right? Yes, if examiner is asking most commonly, then your answer will be BRCA2. right? So now you understand. So this is how you have to solve this question. This is a little bit dangerous question, right? Here just understand the same thing I have written. Male breast cancer mutation BRCA2 is more common than 1, and more than 90% of the male breast cancers are luminal type, right? So more than 90% on molecular classification. Remember, this luminal type is based on molecular classification. So on molecular classification, more than 90% are luminal type, right? Now coming to the next question. All of the following are invasive carcinoma of the breast except. All of the following are invasive carcinoma of the breast except comedo, colloid, lobular, medullary. So what is the answer? Which is not invasive? Anybody? Which is not a question is all of the following are invasive carcinoma of the breast except Mintu Yadav has given me the first correct answer. So this is the right. So here we have to remember that first correct answer is A. Comedocarcinoma is seen in ductal carcinoma in situ, right? So that is the important point. Comedocarcinoma is seen in ductal carcinoma in situ, because in ductal carcinoma in situ, right, what happens when you will see the biopsy, this will be the area of the duct, and in that when you will see the tumor cells are like within the basement membrane, and there will be area of necrosis and calcification like this, right? So there will be area of necrosis and calcification in the center. So when you find area of necrosis plus calcification in the center, that is called as comedonecrosis, right? So which is seen in ductal carcinoma in situ. Colloid carcinoma, lobular carcinoma, and medullary carcinoma, these are all examples of the invasive carcinoma. They are all example of the invasive carcinomas, right? So that is how you have to catch hold that comedocarcinoma is not an invasive, right? So there will be a ductal carcinoma in situ. Tumor cells are there, but they are not crossing the basement membrane, right? and what is characteristic finding? Their central part will be having area of necrosis and calcification. So that is what we call this as a comedocarcinoma, right? So now you can see this is the classification, histological classification of the breast cancer. Cancer breast, non-invasive and invasive. Non-invasive ductal carcinoma in situ, lobular carcinoma in situ, Paget's disease, right? So now you can see there are two in situs, ductal and lobular carcinoma in situs, and then Paget's disease. In invasive carcinoma there are two, lobular and ductal. So now you understand ductal and lobular. Now ductal has several subtypes like tubular, mucinous, medullary, and inflammatory, where you have to understand mucinous is also called as colloid carcinoma, right? So in this option, if you remember, I had given you example of the colloid, I have given you example of the medullary, and ductal was also given, right? So now understand. So ductal carcinoma in situ will be having comedocarcinoma. So you can see here, this is the comedocarcinoma, right? And in this you can see these are the tumor cells, right? So these are the tumor cells, and this is the basement membrane which has not been broken at any place. You can see that basement membrane is intact throughout the area, right? So it has not been broken, so all the tumor cells are here only, right? So here you can see a Cribriform pattern, tumor within tumor mass, tumor within tumor mass. So this is the Cribriform pattern, or you can say glandular pattern. And in this center, when you will look into the center, you can see this area, and this is that blue color is area of calcification, right? So this is the area of calcification, right? So that blue color, and this white, this eosinophilic area is area of necrosis. So necrosis and calcification where you are seeing in the center of the mass, right? So this will be called as comedocarcinoma. So this is the feature of comedocarcinoma, right? So this will be seen in carcinoma in situ. So these are intraductal carcinoma in situ, right, where you are going to see comedocarcinoma, right? This was the invasive ductal carcinoma. So now you can see that the tumor cells are infiltrating. Now you can see tumor cells are infiltrating into the surrounding tissue and they are forming tubules, right? So that is the ductal carcinoma, right? So this will be invasive ductal carcinoma, where they are invading the surrounding stroma. So this eosinophilic collagen, right? So what I am showing you here, these are eosinophilic collagenous stroma, right? And this collagenous stroma has been invaded by tumor cells. So now you can see all these are tumor cells, right? So that is invasive ductal carcinoma. Now coming to the next question, a breast mass lesion and histopathology is given. So you can see breast mass lesion is here and histopathology is here. So which of the following is not true regarding this condition? No, it is not fat necrosis. Case it is not fat necrosis, that is the ductal carcinoma in situ. Tell me what is diagnosis here, if you can put in the comment box. Yeah, it's very good, very good. Nitish has given me the first correct answer. It is B. Right answer is B, because what I'm showing you, this is the erythematous lesion in the area of the nipple, right? So what I'm showing you here, this is the erythematous lesion, which actually described as a eczema like, right? It is not eczema like lesion in the or around the nipple, right? So that we are seeing that the crust is there, right? So there are some crust is formed here, right? So crust is there and is this present. So this is the example of the Paget's disease, right? So this erythematous lesion and this type of microscopic examination, right? What we are seeing in this microscopic examination, you can see some cells are very large. You can notice all these cells which are marking. These are larger cells and their cytoplasm is pale, right? So what I'm showing you, larger cell, right, with pale cytoplasm. And if you look at the nucleoli, you can see prominent nucleoli is also present. Prominent nucleoli is also present. So larger cell, pale cytoplasm, prominent nucleoli. So this is the finding of Paget cell, right? So these are actually Paget cells. So that is how you are going to identify Paget cells in your exam also, right? So how you will identify? They are larger cell, as you can see they are large, right? Large cell. And how is the cytoplasm? You can look into the cytoplasm. Cytoplasm is looking pale if you compare with the surrounding, right? And if you look into them, you can also notice there are prominent nucleoli also, right? So that is Paget's disease, right? So erythematous lesion on gross examination or clinical examination, right? Yeah, that's what. So it is a Paget's disease, and in this what we will understand that Paget's disease is actually having poorer prognosis because they are poorly differentiated, right? So first of all, the first statement is a correct statement. Poorly differentiated, and they are having HER2 new overexpression. So HER2 new overexpression will be present, right? But ERPR will be absent. So that is not a correct answer. ERPR should be negative. So in this, ERPR is negative. So it is not positive, it will be negative. That is why our correct answer is B. HER2 new overexpression will be seen. Yes, that's what Dr. Nitish is telling. That is obvious. It is poorly differentiated, so it will be HER2 new positive, right? They are having poorer prognosis, but it's not always true. So that is also one thing we have to be very cautious. And remember, it is a very rare presentation of the breast cancer. So this is also a correct statement. So correct answer is B. So what I have shown you here, Paget's disease, which is HER2 neo positive, ERPR negative, they are poorly differentiated cancer, and they are a very rare form of the breast cancer presentation, right? So I will just put up one summary of this Paget's disease of nipple quickly. Rare disorders, and they are having association with ductal carcinoma in situ or invasive ductal carcinoma, right? They will have eczema like erythematous lesion, which will be involving nipple, and there will be scaly crust and pruritus. So that is what I said. They will be having eczema like erythematous lesion. They will be having itching and painful, right? So that is why we say that eczema like. So now when we see the tumor cell, what is the characteristic property? You can see this is the basement membrane, and nowhere basement membrane is having rupture. right? So what we are noticing that basement membrane is having no rupture. Basement membrane is having no rupture of the basement membrane. So how tumor cells are entering? So you can notice that tumor cells are now entering through the epidermis, so they're not crossing the basement membrane, right? They are not crossing the basement membrane, they are infiltrating directly into the epidermis, and when tumor cells are infiltrating, so they will cause damage. Because of damage, there will be some fluid will be coming from the cells, which will be forming a scaly crust, right? Now you understand? So tumor cells are infiltrating into the epidermis without causing any damage of the basement membrane, so they will cause damage of the epidermal cells. They will release some fluid, and that fluid will be forming a scaly crust. So that is why no basement membrane rupture, and tumor cells will infiltrate epidermis without basement membrane rupture. So how we'll identify that? They are larger cell, and these larger cells are called as Paget cells. So as I said, large pale cytoplasm with prominent nucleoli. So now understand, they are larger cell, pale cytoplasm with prominent nucleoli. So that is the identification of the Paget cells. So that is how you are going to identify Paget cells in the histological examination or microscopic examination, right? And on molecular analysis, they are ER/PR negative, HER2 new overexpression will be present, and that is why they are poorly differentiated and poor prognostic cancer, right? And this is the lesion which I have shown you already in the question. This is the lesion where you are seeing erythematous, scaly, and weeping eczema like lesions which is involving the nipple, right? So that is how you will identify this can be a Paget's disease of the nipple, right? And microscopic examination, as I have told you, these are the larger cells, right? So what are these cells? Larger cells, right? Pale cytoplasm, and they will be having prominent nucleoli. So that is how you will identify Paget cells on microscopic examination. Coming to the next question, a 50-year-old female presenting with the right breast lump from past 9 months also complains about headache associated with nausea for the past 2 months, and HE section is shown in the figure. Which of the following is not true about this tumor? So what is right answer? Right, so here very good, Nitish and Nairobi has given me the first correct answer. Answer is A. See the history and the presentation. If you look at the presentation, 50-year-old female, right? So here in the question you can see 50-year-old female, right? Right breast lump from the past 9 months. Now she is having headache, nausea, means there is a metastasis of the breast cancer to the brain, right? So what will be the most common cancer in the breast which will be having metastasis? So that is which cancer? Can you tell me in the comment box where you will find metastasis is more common? So that is invasive lobular carcinoma, right? They are most commonly associated with brain metastasis, right? So brain metastasis, or you can also call this as a meningeal metastasis, right? So meningeal metastasis or brain metastasis is more commonly associated with invasive lobular carcinoma. Absolutely correct, Nitish. So in this, what we are seeing in this picture, in this image, histopathology which we are seeing from the patient, now you can notice that this cell, if I am marking this cell here and I am trying to represent like this, there is a lumen in the cell and nucleus has been pushed to the periphery, and other things are mucin is pushing them into the peripheries, right? So this is called signet ring cell, right? So this is called signet ring cells. So signet ring cells are commonly seen in which breast cancer? It is seen in invasive lobular carcinoma of the breast, right? So that is the one thing which we are seeing, signet ring cells, invasive lobular. So clinically that headache is suggestive of meningeal metastasis, and histopathologically we are seeing the signet ring cells which is seen in invasive lobular carcinoma. So our diagnosis is coming to the invasive lobular carcinoma. So our diagnosis is invasive lobular carcinoma, so which is not true about this tumor. So now first option, invasive lobular carcinoma, increased E-cadherin expression. So remember, in invasive lobular carcinoma, E-cadherin expression is decreased, right? E-cadherin expression will be decreased. So this is the false statement, right? It should not be increased, it should be decreased. And because of decreased E-cadherin, what is E-cadherin? It is used for intercellular attachment, right? Intercellular attachment. So what will happen because of lack of E-cadherin? That cell attachment will not be there, so they will detach. So they will become cohesive or discohesive. I understand. So because of this E-cadherin lack, there will be a discohesive tumor cells because they're not attached to each other. So discohesive. So that B option is correct. Discohesive tumor cells. Bilateral metastasis is very common, right? And nucleus is pushed to the one side of the tumor cell, which is a suggestive of Signet ring cell. So this is also right. So what is correct answer? A is correct answer, right? So invasive lobular carcinoma, E-cadherin expression is decreased because of they are discohesive tumor cells, and tumor cells will be having bigger mucin vacuole which is pushing nucleus to the one side. That is why there is a Signet ring cell. So let's have a quick look on the invasive lobular carcinoma. Invasive lobular carcinoma, E-cadherin is absent, as I said. So discohesive tumor cells will be seen and they will be infiltrating the lobules, right? Invasive lobular carcinoma. And how will be the arrangement of the tumor cells? So they are sometimes arranged in a linear pattern, and this linear pattern of arrangement is also called as single file pattern or Indian file pattern. So please remember this name, single file pattern or Indian file pattern. This is a characteristic diagnostic finding of the invasive lobular carcinoma, and usually invasive lobular carcinoma are multifocal and they are very famous for bilateral metastasis of the breast cancer, right? Signet ring cells will be present as I have shown you in this diagram also. Mucin is pushing to the nucleus to the periphery, so that is what in the fourth option it was given, right? And you can notice that invasive lobular carcinoma, Signet ring cell carcinoma, this is also called as Signet ring cell carcinoma because of these Signet ring cells which I have shown you in the images also, right? So these are all Signet ring cells, right? So what I am showing you here, all these are very clear cut Signet ring cells, right? So these are all Signet ring cells which I have shown you in the image, right? If you look at the this picture, so you can see there is another pattern. See, this is the Signet ring cell which I have shown you, and now you can see here they are having single file pattern or Indian file pattern. So this is called as single file pattern or also known as Indian file pattern, right? So Indian file pattern. So what happens here? So you can if you look at the cells, you can see these are the cells which are in a linear fashion arrangement, and what they are doing, they are infiltrating into the, see what I am showing you here, all these are tumor cells, right? All these are tumor cells. And how are these tumor cells? These are actually invading into the surrounding collagen. So this is the collagen. So tumor cells are invading collagen fibers, right? So they are invading collagen fibers. That is what we need to remember here, right? So tumor cells are arranged in a linear pattern, and what they are doing, they are infiltrating into the surrounding eosinophilic. So all these are eosinophilic area is a collagen, and this is the blue cells, small round blue cells. These are all example of tumor cells which are infiltrating into the surrounding collagen, and this appearance is called as Indian file or single file pattern. Yes, it is the only where you do not find calcification on the, yes, you will not find calcification on mammographic examination. That is correct. Absolutely correct, Nitish. Right. Now coming to the 57, next question. 57-year-old female presented with the breast mass. Gross and histopathology is given below. Gross and histopathology is given below. Which of the following is not true regarding this tumor? So tell me, what should be right answer here? Yes, so first correct answer is B by Nitish. It is a, okay, so can you tell me what is diagnosis? Correct answer is B only, right? So I will tell you why it is B, right? I will tell you correct answer is B. Can you tell me what is diagnosis of this cancer? Anybody? What is diagnosis of this disease? Yes, very good, very good. This is the inflammatory type of ductal carcinoma. So this is the inflammatory carcinoma of the breast. Why it is called as inflammatory carcinoma of the breast? Why it is called as inflammatory carcinoma of the breast? Because here what will happen, tumor cells will infiltrate, right? They will infiltrate the lymphatics, right? They will infiltrate the lymphatics of skin of the breast tissue, right? And because of this tumor cell infiltration, what will happen? They will be having swelling and inflammation. So breast tissue will be having swelling and inflammation. So as a result, what will happen to the tissue of the breast? So you can see how is this tissue of the breast? So they are looking dense and thick, number one, right? So that is what I have written here, dense and thick, dense and thick. And what else we are seeing? Because of dense and thick, and lymphatics are getting obstructed. So because of lymphatics obstruction, there will be a dimpling. So you can notice in these area which I am showing you, I am marking with the round area, right? So these are the areas which are showing you dense, thick with dimpling of the breast tissue, right? So dense, thick and dimpled breast tissue, right? Dimpled breast tissue. So this is called as, this dense, thick, dimpled breast tissue is called as PUD orange, right? So this is what we call this as a PUD orange appearance, right? So this is called PUD orange appearance. And PUD orange appearance is seen in which cancer? This will be seen in inflammatory carcinoma of the breast, right? So that is how you will understand inflammatory carcinoma, because of this swelling, because of the inflammation, they usually mimic like a acute mastitis. So first statement is a correct statement. Now understand, because of this infiltration, there is a swelling and inflammation. So because of that, there is a mimicking like a acute mastitis. And remember, this type of breast cancer is having worse prognosis. So they do not have good prognosis. So this is wrong statement. What they will be having? They will be associated with worse prognosis. Tumor cells will block the dermal lymphatics. Because of this blockade of dermal lymphatics only, we are seeing the PUD orange appearance also, and swelling and inflammation also, right? And remember, it is a special subtype of invasive ductal carcinoma, which we have seen already in the histological classification of the breast cancer, right? Tubular will be having good prognosis. Yes, very correct, right? So now I understand. So this is the, so we will have a quick look on the inflammatory carcinoma of the breast. Already I have shown you. And one thing I have forgot to tell you here, in this histopathological image, right, if you look at this, you can see these are the lymphatics, and in these lymphatics you can see lymphatics with tumor cells, right? So here we are seeing lymphatics are there. So because these are extended or dilated lymphatics, so lymphatics will be usually having lymphocytes. So this looks like a inflammatory cells are present in the lymphatic, but when you will see them on high power view, you will find they are hyperchromatic cell, high NC ratio, means all suggestion will be for malignant cells. So that is why these are mimicking like a inflammation, because they are inside the lymphatics, but when you will go closer to them, you will understand these are malignant cells. So that is why it is also called as inflammatory carcinoma of the breast. So inflammatory carcinoma of the breast, clinically it resembles like inflammation, because of that thing which I have shown you. Lymphatics will be having inflammation like tumor cells. So what happened? These cancer cells will infiltrate the dermal lymphatics, and when they will infiltrate the dermal lymphatics, as I have told you, they will obstruct the lymphatics. Lymphatic obstruction will be there, and that lymphatic obstruction what will cause? Because obstruction is there, so infection will be there. So there will be inflammation and swelling of the breast skin. So this inflammation and swelling of the breast skin will be making it thick, dense and thick, and they are having dimpling because of the lymphatic obstruction. So that is why this orange peel appearance is called as PUD orange appearance, right? And they will be having worse prognosis, right? And this is the PUD orange appearance. I have shown you, this is the dermal lymphatics obstruction, and overall breast tissue is thick, right, and dense because of the lymphatic blockade by the tumor cell. And you can see this is the orange peel. So that is what we can see, that this looks like a orange peel. That is why the name is PUD orange breast, right? And this is because of lymphedema or lymphatic obstruction, right? Blockage of the lymph obstruction, right? So dense, thick with dimpling breast tissue. So how we will describe this? Dense, thick and dimpled breast tissue, right? And dimpled breast tissue, and this is all because of blockage of the lymphatic vessels, right? And when you are going to see on microscopic examination, so what we are seeing now, you can see these are the two lymphatics and these are the tumor cells. So we are seeing tumor cells within lymphatics. So on low power view, it looks like some inflammation is infiltrating. So what we have done, we have gone to the high power view, and high power view, when we have seen, then we got the confirmation that these are the tumor cells. So that is how you will find that hyperchromatic tumor cells are present within the lumen of the lymphatics. That is how we will give a diagnosis of inflammatory carcinoma, right? Now coming to the next question. A 34-year-old female with the breast cancer was showing following immunohistochemistry pattern. Which of the following is true regarding this cancer? Which is true regarding this cancer? So for this question, you need to know about the molecular classification of the breast cancer. So what should be right answer here? Tell me. See, I'll just tell you, whenever we do IHC now, it's a very simple rule. IHC sample usually turn out to be brown, right? If it is positive, right? IHC positive means it will be brown in color. IHC negative means it will be pale and blue color, pale and blue in color, right? So whenever you find brown, it means it is a positive. So now you can see that HE section is here, then ER, PR and HER2. Right, so who has given me? No, it's not A. See that, what is ER? Positive or negative? Negative, because there is no brown color. What is PR? PR is also negative because there is no brown color. HER2 is also negative because there is no brown color. So what I am showing you here, it is a triple negative breast cancer. Triple negative breast cancer. So tell me, who is triple negative? Luminal A or luminal B? Because luminal A and B both are ER/PR positive, so obviously it is ruled out. Now who is triple negative? It is basal cell cancer, right? So it is basal cell cancer is triple negative. And what is the prognosis of basal cell cancer? It will be having worse prognosis, please remember. So now option C and D, when you will see they are having BRCA1 positivity, but they are not good prognostic, they are bad prognostic. So answer is D, right? So now understand, to catch this question you should know that whenever IHC is positive, they will be showing you brown color. For your level, you have to understand this much, right? You need not to go for the detail of the IHC, right? And negative will be pale or blue in color. So here you are seeing pale blue. So these are all negative, negative, negative. ER negative, PR negative, HER2 negative, all three negative. So it will be called as triple negative. And triple negative is basal cancer, and they will be having worse prognosis, and they are also having association with BRCA1 mutation. So answer is D. Right, so now I am going to show you the molecular classification of the breast cancer. As I said, there are 5 groups: luminal A, luminal B, HER2, basal, Claudin low. So these are the 5 groups of the molecular classification of the breast cancer. In that 5 groups, first you will see that luminal A and luminal B. See, luminal A and luminal B, what is common to both of them? See, both are luminal. One is A, one is B. So what is common to both of them? Common to both of them is both are ER/PR positive and both are BRCA2 positive. That is very, very important. Understand? So luminal A and luminal B, both are, what is common? ER/PR positive and BRCA2 positive. What is difference? So difference between luminal A and luminal B is of HER2. So luminal A, HER2 is negative. Luminal B, HER2 is positive. That's all. Now understand? So both are, so both luminal is ER/PR positive, BRCA positive and BRCA2 positive, they are HER2 negative. So luminal A is HER2 negative, luminal B is HER2 positive. So obviously if it is negative, so this will be having good prognosis, and luminal B is positive, so it will be having bad prognosis, right? So this is important. So this is not luminal kind of presentation. HER2 cancer is, name itself is telling, it will be only HER2 positive, ER/PR will be negative. So HER2 positive, ER/PR negative, so obviously they will be having bad prognosis because HER2 is positive, right? Basal cell carcinoma, basal cell, HER2, ER/PR, all three will be negative. So this is called as triple negative breast cancer, and they are BRCA1 positive and they have worse prognosis. So this question was about basal cancer because HER2, ER/PR all were negative, right? So they are BRCA1 positive, worse prognosis, right? And Claudin low level. Claudin low level is another new thing which has been added. They are same like a basal, They are also ERPR HER2 negative. They are also having triple negativity. They are having poorer prognosis. But the difference is Claudin. Claudin is a marker of intercellular adhesion molecule. Claudin is a marker of intercellular adhesion molecule. So these Claudin will be having low expression, means decreased expression. So what are those Claudin? Claudin 3, 4, 7, and there will be decreased expression of E-cadherin also, right? So that is the Claudin low type of newly added the breast cancer, right? So they will be having poorer prognosis, right? And now again I will show you, this is the all negative, right? So you can see that this is also negative, this is also negative, this is also negative. So what I have shown you in this question, they are triple negative breast cancer, which is basal cell type of cancer, and basal cell will be having BRCA1 positivity, and they will be having worse prognosis. So this molecular classification is very important, from where examiner will be asking you question. So you can watch my all the playlist of the live lecture, and the most important, the telegram group I will be posting below the comment box, and you can follow that, and I'm going to upload this PDF also. So keep revising this, and this topic is very, very important. Don't miss this. In last 10 to 15 days you must revise this breast topic. You will definitely get question from here, especially from the molecular classification of the breast cancer. So thank you so much to all of you, and I'm really very sorry for the delay of 1 hour because of the internet problem. So hope we will be meeting you soon, and we will be coming